Thank you. Good evening, everyone. So, I hope you all are ready for a very important exam. Yes, beta, I will cover new drugs. Remember, the drugs which are going to ask, I will cover all those new drugs. Okay? Rest, everything will be provided in PDF to you. Okay? So, I hope you all are ready. Always remember one thing told by the greatest teacher, or obviously, which I am not, told by Socrates that I know I am intelligent. The reason is because I know that I know nothing. So, if you know your drawbacks, you are the most intelligent person. If you know where you are lacking, you know that I am ignorant in this part, this is my weakness, only then you can overcome those things. Okay? So, remember always your drawbacks more than your success. So today, what is the agenda? Remember, whole pharmacology I have already covered in 6 hours for NEET Sure Short series. For NEET Sure Short series, I have already covered whole pharma. Today, in a 2-hour session, we will discuss previous 3 years PYQs and related concepts, the questions which might be asked in your INI-CET exam. Apart from questions, I will be telling you certain important points also. Try to mug up right now. Okay, try to mug up right now because not much days are left for your INI-CET exam. So, without wasting your all precious time, let's start with the first question. This was question which was asked 6 months back. Which antimicrobial binds to D-alanine and inhibits cell wall synthesis? Thank you, Stephen. Which antimicrobial binds to D-alanine? I'm waiting for your answer. The answer for the question is vancomycin. Fine. Now, I will tell you a simple way to remember cell wall synthesis inhibitor. Remember a mnemonic BBC, very famous. Okay. These are the various cell wall synthesis inhibitor. B for beta lactam group. And you know that in beta lactam we have 4 antimicrobials like penicillin, cephalosporin, carbapenems. All penicillins will end with the word cillin, amoxicillin, ampicillin, piperacillin. All cephalosporin they will start with the word cepha. Agree? Or carbapenem will end with the word penem like imipenem, meropenem, and one drug aztreonam which comes under a group monobactam. Now we know that cell wall of a bacteria is made up of peptidoglycan. That means there are peptides and glycans. So these 4 drugs they inhibit transpeptidase. They inhibit transpeptidase enzyme. Hence, amino acids will not able to link. The second drug is bacitracin. You don't have to remember the mechanism of action of bacitracin, but I have already told you in lectures. Cycloserine. Cycloserine inhibits addition, linkage of amino acid. Which amino acid makes peptido part? Alanine. So it inhibits alanine ligase and alanine racemase enzyme. B for vancomycin group. Vancomycin inhibits transglycosylase enzyme because it inhibits attachment of glycans. How? By binding to, I will show you a diagram shortly, to D-alanine moiety. D-alanine and D-alanine moiety it inhibits. Last drug, which is a cell wall synthesis inhibitor, is phosphomycin. Now, a recent question in phosphomycin was, what is the dose of phosphomycin? Remember, phosphomycin is given for the treatment of UTI and the dose is 3 grams per oral. 3 grams per oral stat dose. Okay, these are the important MCQ you must remember. Let's come to this is a cell wall diagram. This diagram is sometimes asked from you people. Okay, sometimes it is also asked. So I will tell you one point. This is cycloserine. You can see alanine and alanine are linking together. So we inhibit by cycloserine. Beta-lactam, they inhibit cross-linking transpeptidase enzyme. Vancomycin, it inhibits attachment of glycans by binding to D-alanine and D-alanine moiety. Mug up right now. Okay, this is not the time to build concept. Now tell me the answer of second question. Let's see who can answer the second question. Let's see who can answer the second question. So, a patient who was newly diagnosed with tuberculosis was found to be, a patient is having tuberculosis, was found to be HIV positive. Regarding the treatment of this patient, which of the following statements will be true? So, you have to find a true statement among this. Yes, I am seeing, I am still waiting for your answers. So, what is the answer? Yes, I think you all are absolutely right. Remember one rule. Remember one rule. You know that in HIV, there are various opportunistic infection. Various opportunistic infection. What to treat first? You know that in HIV there is TB, opportunistic infection, pneumocystis infection. You know, toxoplasma can happen, herpes can happen, candida can happen, and CMV virus infection can happen. Now remember, in the treatment of HIV, we give a drug ART, antiretroviral therapy, and these are the opportunistic infection. These are the opportunistic infection we know. Now remember one rule. Whenever the patient is coming to you with both HIV with some opportunistic infection, first you have to treat opportunistic infection. Why? Because the main cause of death is opportunistic infection, and then you start ART. So if I say TB, let's talk about TB. First give ATT, and after 2 to 8 weeks, best answer is 2 weeks, start ART. Now which ATT to be given? Same. HRZE treatment is absolutely same, which is given in normal person. Pneumocystis, we give cotrimoxazole, which is the drug of choice. Again 2 to 8 weeks, we start ART. Toxoplasma, we give sulfadiazine with pyrimethamine. Remember, pyrimethamine is one antibiotic which inhibits dihydrofolate reductase enzyme. It inhibits the conversion of folic acid into folinic acid. Hence, we always add folinic acid with sulfadiazine pyrimethamine combination. With herpes group of virus, we start with acyclovir and then we start ART. For candida, we give fluconazole and then we start ART. And lastly, for CMV, we start with ganciclovir, then we start ART. So this is the treatment of all opportunistic infection. No beta, rifampicin is given in HIV because nowadays the anti-tubercular therapy which are given to our patient is tenofovir, tenofovir, lamivudine and dolutegravir. Now the point is, if you are giving rifampicin with this ART, the only thing you have to do is you have to double the dose of dolutegravir. Remember, we give rifampicin, but we increase the dose of dolutegravir in cases of HIV infection because rifampicin increase the degradation of dolutegravir because rifampicin is an enzyme inducer. I hope one student asked a very good question about rifampicin. I hope your answer is taken care of. Let's come to the next question. Fixed dilated pupil. This was asked 1 year back question. Fixed dilated pupil will not be produced by this drug. Anyone, what is the answer? Anyone, what is the answer? So we will discuss all the drugs that will act on eyes shortly. So the answer for this question is pilocarpine. Pilocarpine does not produce dilated pupil. Pilocarpine rather produce constricted pupil meiosis. Okay. Now remember, these three drugs increase sympathetic activity. Parasympathetic activity is increased by pilocarpine. Very good. So let's discuss all the drugs that act on iris. Now you can see this picture, and in this iris there are two types of muscles which you can appreciate. The first muscle, I'll label it for you. You can see this muscle which I have highlighted with white color. So it is just like a radius of a circle. Don't you think it is just like a radius of a circle? So this muscle is known as radial muscle. Now just remember, if you contract radial muscle, the size of the pupil will reduce because contraction reduce the muscle length, है ना? Contraction reduce muscle length, size of the pupil will reduce. Another name of this muscle is sphincter pupillae. Sphincter pupillae. Now the second type of muscle, just appreciate, I am marking like this, like the straight muscles. I'm really sorry, please make it circular muscle. In a hurry, I have told you circular. Circular, why? Because it is a radial circle. It is just like a circle. Now the second type of muscle which you can see is, which I am drawing right now. This muscle is known as radial muscle. Why? Because it is just like a radius of a circle. This is also known as dilator pupillae. Okay, and this muscle, if it contracts, it produces mydriasis. Fine. Now the drug which contract circular muscle will produce active meiosis. Do you agree with this point? And we have parasympathetic nervous system drug, that is pilocarpine. Second point, the drug that will contract radial muscle will produce active mydriasis. I hope you have understood this point. And we have sympathetic nervous system drug like phenylephrine. You have to remember the name. Amphetamine. And one local anesthetic having sympathetic activity, cocaine. Fine. Now additional point, very important, if you relax or paralyze this muscle, what will happen? If you paralyze this muscle, it will produce passive mydriasis. Paralysis of sphincter pupillae leads to passive mydriasis. And which drug produce passive mydriasis? Anyone? The drug which will decrease parasympathetic activity. That means anticholinergic drugs. And any drug you know anticholinergic? Yes, atropine, cyclopentolate, and homatropin. Now tell me, bachcha log, any difficulty out here? Any difficulty out here? What do you mean by active meiosis, active mydriasis, and the difference between active and passive mydriasis? And the difference between active and passive mydriasis. Very good. You all are absolutely right, giving the correct answer to me. Now tell me, recent question, Very small topic, very commonly asked. Tell me the answer of this question. Continuous inhalational nitric oxide is given in the treatment of which disease? In which disease we use inhalational nitric oxide? Anyone? Scissors, migraine, pulmonary artery hypertension, or Parkinson disease? This was the exact question which came, and it's a very so commonly asked question. So the answer is pulmonary artery hypertension. Now, before coming to the treatment of pulmonary artery hypertension, tell me the answer of this follow-up question. The question I am asking you, a follow-up question, use of antidepressants like SSRI. Let's say I am writing one SSRI, paroxetine, in pregnancy leads to which abnormality in fetus? Now tell me the answer. This was a recent question. If a mother is taking antidepressants like paroxetine, P we can remember, paroxetine in pregnancy leads to pulmonary artery hypertension in fetus. It's a follow-up question. I will discuss all the follow-up questions as well. I hope you will never forget it. Now let's see the drugs which are used for pulmonary artery hypertension. Remember, in pulmonary artery hypertension, we use vasodilators because vasodilators will reduce pulmonary artery pressure. Vasodilators will reduce pulmonary artery pressure. Fine. Pulmonary artery pressure. Now the mnemonic for drugs is Pepsi, Coca-Cola. First drug you must remember always is prostaglandin I2 analog. Okay, and three drugs are approved: TIE, TIE, TIE. We can remember TIE, and they will have prost word in it. So treprostinil, iloprost, and epoprostinol. And they are the drug of choice for pulmonary artery hypertension. Yes, beta, passive mydriasis occurs in iris. Cycloplegia occurs in ciliary muscle, which is above the lens. Which, yes, atropine is also a cycloplegic. Yes, you are absolutely right. Second is endothelin. Endothelin causes vasoconstriction. Hence, we give endothelin antagonist. So, very famous drug, you all know, bosentan. How to remember? Endothelin ANT antagonist. Easy to remember. So where bosentan is used? Pulmonary artery hypertension. Very good. Then phosphodiesterase 5 inhibitor. Phosphodiesterase 5 inhibitor. Sildenafil, tadalafil. You know that sildenafil, it comes with a brand name Viagra. It is also used for impotence or erectile dysfunction. Another use of Viagra apart from impotence is pulmonary artery hypertension. So tell me the two uses of sildenafil: pulmonary artery hypertension and impotence. Impotence means erectile dysfunction. Then we have soluble guanylyl cyclase activator. The drug name is Riociguat. How to remember the name of this drug? GU means guanylyl cyclase, AT means activator. AT means activator. There is another drug known as Vericiguat. Don't you think it is also ending with the word guat only? Guanylyl cyclase activator. This drug is not used in pulmonary artery hypertension. This drug is used in CHF, that is chronic heart failure. This drug is rather used in chronic heart failure. Riociguat, pulmonary artery hypertension; Vericiguat, chronic heart failure. Then we have I2 type of prostaglandin receptor agonist. Same like first drug, Selexipag. How to remember? Very easy to remember. See the name I2 type. P for prostaglandin, AG for agonist. Remember, you can remember. Then we have continuous nitric oxide inhalation, which is the answer of our question. And lastly, calcium channel blocker like nifedipine, amlodipine. Nifedipine and amlodipine. Now, follow up question. Okay. Don't worry, Chandrakant. I'll personally talk to PW team. They are very dedicated team. They will connect back to you. Now, just remember one important question about sildenafil and tadalafil. Remember, these sildenafil and tadalafil, these drugs should never be combined with nitrates. Remember, nitrates, they are used in angina and MI. Erectile dysfunction also occurs in old age. Angina and MI also occurs in old age. Because if you will combine sildenafil and tadalafil with nitrate, it will lead to massive hypotension, which will lead to sudden death. So tell me, sildenafil and tadalafil should not be combined with which drug? They should not be combined with nitrates. Next question. Let's see who can answer it. This is a very repetitive question. Very repetitive question. Drugs for nasal carrier state of MRSA. Now, whenever we hear a word MRSA, we straight away jump over to vancomycin. Remember, no. First, read the question full, then jump over to the question. So, for the nasal carrier state of MRSA, which drug to be used? Anyone? What is the answer? So, I have given you 4 questions. Tell me. Yes, Abhinav, absolutely right. Bharti, we will come back to C. So that is why I have asked this question. You should not get confused. The answer for our question is mupirocin cream. Mupirocin cream is the correct answer. Okay, it is not linezolid. It is not linezolid. Let me teach you about MRSA. We know that MRSA is methicillin resistant staph aureus. Let's not go to the detail of MRSA. Let's talk about the drugs for MRSA. Now, this is a very important topic, MRSA. Drugs for MRSA. Remember, first class of drug we are having is IV drug. IV drugs are given for serious infection like meningitis, etc. Okay, toxic shock syndrome, etc. Then we have oral drug. Oral drugs are given for skin and soft tissue infection because this is not as dangerous. And lastly, we have a topical drugs. Topical drugs are given for killing nasal carrier state. Have I made myself absolutely clear to all of you when they are used? So, IV drug for MRSA. The IV drug is vancomycin. So, if somebody will ask you what is the IV drug of choice for MRSA, vancomycin, you can also use a brother of vancomycin known as teicoplanin, which is also available in our country and very commonly used in our hospital settings. Fine. If there is VRSA, you know what is VRSA? Vancomycin resistant staph aureus. We give linezolid. Now, if you find LRSA, that is linezolid resistant staph aureus, we give streptogramin. Fine. If you find SRSA, then we give daptomycin. But remember, daptomycin is not given in pneumonias. Why not in pneumonia? Because the surfactant degrades daptomycin. This was a question which was recently asked. Okay. Don't worry, Sohit Tiwari. I will teach both in English and Hindi. Okay. I know Hindi very well. I know English very well. I know Punjabi also, plus some other languages also. Don't worry. If you will not understand in two language, I will use the third language to make you understand. Second drug is tigecycline. And lastly, fifth generation cephalosporin. Now, fifth generation cephalosporin, they will have a roll word in them like ceftaroline. Any problem? Roll word is coming. And ceftabiprole. Ceftabiprole. Problem done, solved. Now, there is a confusion out here. Let's understand this confusion. Remember, Harrison says that if the patient is having VRSA, Harrison says if the patient is having VRSA, straight away start daptomycin. Harrison says that if there is VRSA, don't wait for linezolid, streptogramin, and daptomycin. Streptogramin, directly start daptomycin. So now the drug of choice for VRSA has become daptomycin. But daptomycin is also effective in LRSA, VRSA, SRSA. Any confusion in that, bachalo? Tell me, any confusion? No. Oral drug. Again, I will write linezolid because linezolid is oral also. IV also, oral also. Very important drug. Clindamycin, fluoroquinolone, tetracycline like doxycycline and minocycline, and cotrimoxazole. Although rifampicin was earlier used, rifampicin is also written sometimes in oral, but we will not go. Now, remember, you just have to remember one drug among them. Just try to remember this drug in oral. You have to remember all drugs in IV. You have to remember one drug in oral. Which drug you have to remember in oral drug? Clindamycin. I will come back to clindamycin shortly. Topical drug. Very important. The answer for our question was mupirocin cream. What is the strength of mupirocin cream? 2% cream. Any other drug? Yes. Fusidic acid is also used for topical treatment of. No beta, vancomycin for MRSA is not given orally. For Clostridium difficile infection it is given orally, which we will discuss shortly. Adnan Ismail, understood? Because Clostridium difficile causes infection in colon only. So when you give vancomycin, it will kill infection in colon only, it will not get absorbed. Yes, Bhargavi, I will share this PDF with you. Within 10 to 15 minutes of ending this lecture, you will get this PDF on Telegram group. Fine. Okay. Now to follow up question. Okay. So this is just for your ease. I have made a slide for you. Now to follow up question. First, the question which is asked is toxic shock syndrome toxin. You know it is caused by mainly staph and strep. Now treatment. The drug of choice is IV vancomycin plus clindamycin. Clindamycin can be given IV and orally also. Now the why? Vancomycin to kill bacteria. Now this is a question. Why we give clindamycin? Clindamycin to reduce toxin production. Why we gave clindamycin? To reduce toxin production. Any point, any problem out here? Next infection you must remember is Clostridium difficile infection. You know that Clostridium causes pseudomembranous colitis. And why it happens? It happens because of overuse of antibiotic. Overuse of antibiotic can kill our good bacteria in GIT. And when they kill good bacteria in GIT, this harmful bacteria can grow. So the highest risk is with clindamycin. So you just have to remember which antibiotic has highest risk of causing. Some antibiotic have lower risk, but some are highest. Highest is clindamycin, followed by third generation cephalosporin, followed by one penicillin, ampicillin, and lastly fluoroquinolone. So remember 4 antibiotics which have highest risk of causing Clostridium difficile infection. Understood this point? Treatment. The drug of choice is oral vancomycin. Now I will clear a confusion with fidaxomicin also. Okay. Another new drug is fidaxomicin. Fidaxomicin. What is fidaxomicin? A macrolide antibiotic. So here remember I am giving oral vancomycin. Fine. Third drug, metronidazole. Which monoclonal antibody has been approved? Very commonly asked question. Toxumab. How to remember? Tox. It is against toxin B of Clostridial difficile infection. It is against Clostridium. Yes, this is super infection. We already discussed Adnan in our normal regular lecture. Because if you will kill good bacteria, this harmful bacteria will grow. Super infection. Very good. Very good. Okay. Now the point is, remember, fidaxomicin, it is the most effective drug. And it is the drug of choice in America, according to American guideline. The reason is fidaxomicin is not available in India. Fidaxomicin is not available in India. So tell me, in India, what is the drug of choice? In India, the drug of choice is vancomycin, according to ICMR guidelines. Okay, according to ICMR guideline. In USA, according to IDSA guideline. You don't have to remember the name of guidelines. Okay, fidaxo is not available in India. Lastly, you can replace good bacteria. So you can do fecal microbiota, that means good bacteria which are obtained from feces. We can transplant them. So this is the treatment of Clostridium difficile infection. Fine. Let's come to the next question. Tell me the drug which has been approved for long-term treatment of obesity. Drug which has been approved for long-term treatment of obesity. Metformin, sibutramine, liraglutide, fenfluramine. Now I will tell you, metformin causes weight loss, but it is not approved for obesity. Sibutramine causes weight loss, weight loss, weight loss. Sibutramine has been banned. Fenfluramine has been banned. Reason? These drugs were causing cardiac valve defects. They were damaging heart. Damage of heart is more dangerous thing. So answer for our question is liraglutide. So the answer of this question is liraglutide. Let's discuss all anti-obesity drugs which have been approved at one place. So these are the approved anti-obesity drug. The first you can see is a combination of two drugs. Combination of which two drugs? Pronounce it mefentermine. Mefentermine and topiramate. Mefentermine, topiramate. Second is bupropion. We will come back to this drug also. Zonisamide. Now the question in first two will come is that this topiramate and zonisamide, these two drugs are anti-epileptic drugs. These two drugs are anti-epileptic drug. So the question is, which anti-epileptic drug causes weight loss? Which anti-epileptic drug causes weight loss? Topiramate and zonisamide. Another follow-up question. Which anti-epileptic drug produces a side effect of secondary angle closure glaucoma? Follow-up question which was recently asked. Which anti-epileptic drug causes secondary angle closure glaucoma? Again, topiramate and zonisamide. And lastly, renal stones. So which anti-epileptic drug causes renal stones and glaucoma? Which is approved for? Now second is liraglutide. Remember, any drug that ends with the word glutide is a GLP-1 analog. They are used in diabetes mellitus. GLP-1 stand for glucagon-like peptide. Glucagon-like peptide. Now, a follow-up question. Which drug is given? Liraglutide is given by which route? Very commonly asked question. Liraglutide is given by injection. Which glutide can be given orally? Semaglutide can be given orally. Semaglutide is an oral GLP-1 analog. This is a separate question. Okay. Liraglutide, semaglutide. Liraglutide is injection. Semaglutide is oral. Follow-up question. These are oral. Least chat word is coming. Li means lipase. See the name. OR means oral. Li means lipase. Stat means inhibitor. So they inhibit lipase enzyme in our GIT. In our GIT. Understood this point? Very good. Let's jump to the next question. Now, this was a new question which was asked previous year. This question has not been asked till now. Let's try to understand this question. A drug approved in Europe. So let's imagine there is a drug which is already getting sold out in Europe. But now we want to market this drug in India. Now you want to sell this drug in India. Which phase of clinical trial a drug must be tested first? Anyone who can tell me the answer? Good. Amber, very good. Amber Agarwal, proud of you. Any other student? Yes, you all are right. Remember, the answer for this question is phase 3. Phase 3. Okay? Because you want to market this drug, and if the drug, remember, if the drug is already sold in Europe, there is no need of phase 1 and 2 trial. You have to do in India, you have to do just phase 3 trial, and then the drug will be approved. Okay, and these type of trials, they are known as bridging trials. Don't you think you are bridging a gap between two countries? So this type of trial is known as bridging trials. Now after market approval, you do which trial? After market approval, you do phase 4 trial. Okay, phase 4 trial. Phase 4 trial is also known as post marketing surveillance, to keep check on a drug after the drug comes into the market. Fine. Remember, phase 1 trial, it is done for safety and pharmacokinetics. How we try safety of a drug? Remember, safety of a drug, we check by different dose till what dose the drug is safe. That maximum dose at which the drug is found to be safe is known as maximum tolerable dose. So in phase 1 trial, what do we find? Safety, pharmacokinetics, and maximum tolerable dose. Phase 1 trial is not done for question. Phase 1 trial is not done for, who can tell me the answer? Phase 1 trial is not done for efficacy. Phase 1 trial is not done for efficacy. Phase 2 and 3, they are done for efficacy. And when you do check efficacy, remember, we explore efficacy in phase 2 and we confirm efficacy in phase 3. And these type of trial, what is the design? RCT with blinding. Phase 2 and 3 trial are randomized control trial with blinding. All the questions of phases of clinical trial will come from here only. Okay, all the questions will come from here only. So which phase is RCT with blinding? Phase 2 and phase 3. Okay, fine. Now let's come to topiramate is used in anyone. Topiramate is used in all of the following condition. Yes, but remember, it is only approved for, I'm really sorry, it is approved here in a type of epilepsy. It is used in a type of epilepsy. It is approved. Heat stroke prophylaxis, it is not approved. Any drug which is not approved is known as off-label use. ADHD, yes, not approved. Off label use. What about migraine? Not for treatment. Topiramate and anti-epileptic drug, they are given for prophylaxis of migraine. They are rather given for prophylaxis of migraine. Fine. So the answer is epilepsy, Lennox-Gastaut syndrome. Remember two new drugs for Lennox-Gastaut syndrome. Drug of choice is valproate. Okay. But new drugs for, you can also use lamotrigine. You can also use topiramate. But drug of choice is valproate. New drug is felbamate. Another new drug is rufinamide. Rufinamide. Let me teach you newer anti-epileptic drugs. Okay, newer anti-epileptic drugs. So which questions can come on anti-epileptic drugs? The first is vigabatrin. This is a very commonly asked question. Vigabatrin. Vigabatrin is GABA, transaminase inhibitor. What is left is VI. Side effect of vigabatrin. You'll write visual field contraction. Side effect is visual field contraction. Last year's question. Okay. Last year question. Visual field contraction. Use. Infantile spasm. Now, what is another name of infantile spasm? Last year's question. West syndrome. Associated with tuberous sclerosis. Associated with tuberous sclerosis. We give this drug. Now remember, if it is not associated with tuberous sclerosis, let's say it is isolated, not associated with tuberous sclerosis, then the drug of choice is ACTH hormone. ACTH suppresses CRH hormone by negative feedback. Okay. So remember, this name was asked. ACTH hormone is given in the treatment of which type of seizures? Infantile spasm. Vigabatrin causes visual field contraction. I hope you have understood. Okay. Another drug, retigabine, which is also known as ezogabine. Retigabine, ezogabine. It opens potassium channel. Only drug which open potassium channel is retigabine or ezogabine. Remember, it should be avoided with phenytoin, because both drugs are given for focal seizures. The reason is phenytoin increases CYP activity, which increase metabolism of retigabine. Now think logically and tell me, the question which was asked is, if you are combining retigabine with phenytoin, the dose of retigabine should be increased or reduced. All anti-epileptic are enzyme inducers, CYP enzyme. CYP cause degradation of drug. So tell me, if you are combining with phenytoin, you have to increase the dose of retigabine. So I'm just discussing all the previous INI-CET questions with you. Okay, all the INI-CET questions with you. Fine, good. Chalo. Next question. Very commonly asked topic, antidotes for anticoagulant drugs. Tell me which is an incorrect match. So here we have anticoagulant drug, and here we have written antidotes. Tell me which is the incorrect match. Doc Murphy, we have to increase the dose because CYP activity when increased degrades the drug. It degrades retigabine very fast. So you have to give at least double the dose of retigabine. Yes, Shashikala has answered correctly. That's great. The answer for our question is tiraparentag. The answer for our question is tiraparentag. So let's understand all antidotes at one place. Fine. So antidotes of anticoagulant. Now you know warfarin. Warfarin competitively inhibits which enzyme? C1 enzyme. That is vitamin K epoxide oxidoreductase. Tell me the antidote of warfarin. Logical antidote is vitamin K1, which is also known as piloquinone. Now, any drug that ends with the word exaban, exaban, exaban is a factor 10A inhibitor. है ना? Exa means 10A. Now tell me the antidote. The antidote is andexanet. Antidote is andexanet alpha. How we can remember andexanet? You can see dexa word is coming or exa word is coming. It is a recombinant form of factor 10A. It is recombinant form of factor 10A. Now dabigatran, D for direct, TR means thrombin, ANT means antagonist or inhibitor. The antidote of direct thrombin inhibitor dabigatran is one monoclonal antibody idarucizumab. Very commonly asked question. How we can remember? You can see daru word is coming. Very few. It is the only monoclonal antibody which directly blocks dabigatran. Remember, daru word is coming. Daru word we can remember. So dabi word is coming. Remember one mnemonic. Daba ke daru piyo. Okay. Daba ke daru piyo. Okay. Daba ke daru piyo. Idarucizumab. It has K word in it, not C. Then high molecular weight heparin, protamine sulfate. Now one question came on protamine sulfate. There are three types of heparin. One is high molecular weight, low molecular weight and ultra low molecular weight. Three types of heparin we have. Protamine sulfate is less effective against low molecular weight heparin. Example, enoxaparin. It is less effective against low molecular weight. It is the main antidote of high molecular weight. Second point, it is not effective against ultra low molecular weight heparin. Ultra low molecular weight heparin, they will end with the word perinux. Can you name any drug with perinux word? Perinux, Perinux. So we don't have antidote for ultra low molecular weight heparin. Okay, in one word. So we don't have antidote of which anticoagulant drug. There is no antidote for Perinux, Perinux, ultra low molecular weight heparin. There is no antidote. Hirudin, bivaleuridin, direct thrombin inhibitor. For them, we don't have any antidote. Try to remember this word. Understood this point? Good. But what we did, we attached biotin with idraperinux. With this idraperinux, what we did, we made a drug idrabiotaperinux, because with this we attach biotin. For this drug, we have antidote. Antidote for this drug is avidin. What is the antidote? Avidin. If you remember your PSM, avidin binds to biotin. Avidin binds to biotin. Now a new drug, siraparentag. It is a non-specific antidote for all these drugs which we have written. except warfarin. Except warfarin, it is the non-specific antidote for factor 10A inhibitor, dabigatran, high molecular weight heparin, low molecular weight heparin. Fine, easy हो गया काम. So this slide you will get as a PDF. Don't worry about that. Let's discuss this question. Very frequently asked question. A female taking some drug, we don't know ART why she's taking, but she complains of migraine. She complains of migraine since 4 days. She took ergotamine for the treatment. Very simple question, now we know. Now she complains tingling and pain in toe, upward till mid thigh. Examination shows no pulse. Remember, ergots, they produce vasoconstriction, and vasoconstriction will lead to dry gangrene. Dry gangrene means ischemic necrosis of fingers. So remember, if you take ergot, how we can remember? If we take ergot, so remember one statement, ergot, fingers will rot. So can we remember this statement? If we take ergot, the fingers will rot. And this disease is known as ergotism. This disease is known as ergotism. This disease is known as ergotism. What is the treatment of ergotism? Give a vasodilator nitroprusside. Give a vasodilator nitroprusside for the treatment of ergotism. Fine. Next question. Which thiazide can be given in low GFR, less than 30 ml per minute, for the treatment of hypertension? Okay, for the treatment of hypertension. What is the answer? Anyone? Waiting for your response. The answer for this question is metalozone. Now remember, first point, the drug of choice among diuretic in renal failure. The drug of choice among diuretic in renal failure is loop diuretics. Okay, but two thiazides are also safe, which can be given in renal failure. The first is metalozone, second is indapamide. These two drugs can be given as an add-on drug to loop. These drugs can be given as an add-on drug to the loop. Okay, fine. कोई बात नहीं बेटा. If you are not able to any technical, you are not able to answer, don't worry. Okay, here if you hear more, you are more intelligent. Okay, don't worry. Now let's talk about few important points about diuretic. Now, use of diuretic. First, you'll write edema. Let's talk about edema. Edema in heart failure. Can you tell me edema in left ventricular failure, which occurs is pulmonary edema, and right ventricular failure, pedal edema, which leads to anasarca. Second, renal failure, like nephrotic syndrome. Okay, nephrotic syndrome. Let me check. Right ventricular failure. So you know periorbital edema. Similarly, in liver failure, ascites. Lastly, in increase intracranial pressure, which you call it as cerebral edema. Here, the drug of choice is loop diuretic like furosemide, bumetanide, loop diuretic. In liver failure, the drug of choice is spironolactone. Spironolactone is a potassium sparing diuretic. And in cerebral edema, mannitol. Mannitol is an osmotic diuretic. Fine. Now remember, if you are not able to control, this is known as refractory edema. This is known as refractory edema. I hope you have understood. So loop diuretic are given in all types of edema. But remember one thing, you cannot go from here to here. Never. Now, can you tell me mannitol is not given in? Who will tell me the answer? Mannitol is not given in heart failure and renal failure. We never give mannitol in heart failure and renal failure. Additional question. Mannitol, it is also the drug of choice for dialysis disequilibrium. Mannitol is given for dialysis disequilibrium. Because in dialysis, osmolarity of plasma reduces, mannitol increases plasma osmolarity. Fine. Similarly, to additional point, thiazide. Thiazides are given for the treatment of calcium renal stones. Because thiazides, they preserve calcium. They inhibit the excretion of calcium. Second, one another diuretic, acetazolamide. Which diuretic is given in the treatment of glaucoma? Acetazolamide, which is the drug of choice for mountain sickness. The drug of choice for mountain sickness is acetazolamide. Okay? Drug of choice for mountain sickness, acetazolamide. So these are the points you must remember among diuretic chapter. Let's come to this question. Very frequently asked question coming repetitively from past 5 years. Let's understand this question. Yes, beta Bhargavi, you are absolutely right. You know the reason also. Acetazolamide increase ammonia level. Now, a patient of ischemic stroke was given Clopidogrel, but still after 5 months, the patient had another attack of stroke. Genetic deficiency of which enzyme is responsible for failure of clopidogrel therapy? Now remember, if you see the word clopidogrel, just see the first two words. Clopidogrel, first two words. Now can you tell me which first two words they correspond to which CYP enzyme? Which CYP enzyme do you think it will be? C1, C1. Can we remember C1 like this? Can we remember C1 like this? So remember, clopidogrel is a prodrug. Prodrugs are inactive drug and they get converted into active form. As an active form, it is an antiplatelet drug. Antiplatelet drug are given for the treatment of MI and stroke. And they get converted into active form by CYP2C19. CYP2C19. So, genetic deficiency of this enzyme will lead to clopidogrel will not be converted into active form. Now remember, there is a drug which inhibits CYP2C9, that is omeprazole, PPI. So omeprazole is a PPI with maximum CYP inhibiting action. It is an drug with maximum CYP inhibiting action. Hence omeprazole should be avoided with clopidogrel. It will inhibit the conversion of clopidogrel into active form. So which PPIs are safe? The PPIs which are safe with clopidogrel are rabeprazole and pantoprazole, because rabeprazole and pantoprazole, they have least CYP inhibiting action. They have least CYP inhibiting action. I hope you have understood the basic concept. So remember, clopidogrel, CYP2C19, omeprazole, these words you must remember, very commonly asked question. Let's jump to the next question. First order kinetic. In first order kinetic, if the drug dose is doubled, then what happens? Anyone? It's a confusing question. Half-life doubles. Half-life remains unchanged. Plasma concentration and half-life doubles. Plasma concentration and half-life remains unchanged. What is the answer? Yes, Bhargavi ji, Amit ji, to the point answer. Very nice. Yes. So the answer for this question is half-life remains unchanged. Okay. Half-life remains unchanged. Great. So remember one point always, that in first order kinetics versus zero order kinetics. In first order kinetic, elimination of a drug is directly proportional to plasma concentration. First, in zero order kinetic, elimination is constant. Fine. Second point, in first order kinetic, half-life of a drug is constant. While in zero order kinetic, half-life is directly proportional to plasma concentration. So, if I will ask you, what will happen to half-life of a drug in zero order kinetic if I double the plasma concentration? If I double the plasma concentration, what will happen to half-life of a drug in zero order kinetic? Remember, in zero order kinetic, the half-life will also double. Fine. But here, there it will remain constant. Whatever happens, it will remain constant. So you can remember these points. What is constant and what is directly proportional. So this is a slide which you will be getting. Try to understand this slide, how the drug is getting eliminated and what all things remain constant, what all things remain. Yes, Amit, you are absolutely right. So this is important slide for you, which will be provided to you. Don't worry. Now tell me, not a priority for essential drugs. Not a priority for essential drugs. Essential drugs should be safe in large population. They should be cost effective. They should be available as FDCs, fixed dose combination, and they are given for large prevalent disease. What is the answer? Yes, Sasikala, you are absolutely right. The answer for our question is they should not be combined with other drugs. FDCs, fixed dose combination. So remember, essential drugs, they are given for highly prevalent disease. These drugs should be available at all time, all types of formulation, all types of dose. They should be cheap. Cheap means cost effective, a person can afford essential drug, and they should not be combined with other drugs. Because if you will combine with other drugs, it will unnecessarily increase the price of a drug. And recently, WHO has given out a list known as EDL, Essential Drug List 2022, and it contains 479 drugs. It contains 479 drugs. Fine. Let's come to the next question. An old age patient undergoing treatment for cancer presented with fever, lab investigation relieved low hemoglobin of 9, neutrophil count is also low, absolute neutrophil count if it is less than 500, we call it as agranulocytosis, that is bone marrow suppression, and low platelet. So can we say the patient is having bone marrow suppression? Which antimicrobial should be avoided in bone marrow suppressed patient? The answer for our question is linezolid. Linezolid is a very commonly asked question. So remember, three side effects of linezolid, very important. Remember a mnemonic: comp. Yes, Bhargavi, you are absolute. Now, first side effect we already know is bone marrow suppression, which is the answer. Other side effect, it damages eyes. In eyes, it causes choreo, retinitis, and optic neuritis. Easy? Eyes. Okay? Lastly, which antibiotic inhibits MAO enzyme? MAO is monoamine oxidase inhibitor. Another follow-up question is linezolid is a MAO inhibitor. Okay? It is a monoamine oxidase inhibitor. Fine. I hope you can remember this point. Next question. Patient with glaucoma, there is an increase in intraocular pressure. So glaucoma, we know there is increase in intraocular pressure. And this patient is having uveitis. That means inflammation in eye. Now what happens in inflammation in eye? Eye becomes red. There is corneal inflammation, corneal deposition, aqueous flare. Which drug should be avoided in glaucoma with acute uveitis? I have told you the trick also when I was taking a regular lecture. Remember, prostaglandins in our body increase inflammation. You know, prostaglandin increase inflammation. So prostaglandins increase inflammation. Similarly, we have non-steroidal anti-inflammatory drug like aspirin, paracetamol. They decrease prostaglandin, hence they are anti-inflammatory. Fine. So the answer is this. Now, this drug is important for glaucoma. So in glaucoma, we use prostaglandin F2 alpha agonist. F2 alpha agonist. These drugs, they increase uveoscleral outflow. And these drugs, yes, Bhargaviji, you are absolutely right. They are the drug of choice for primary open angle glaucoma and angle closure glaucoma any type. So you can see that these drugs are ending with the word prost. Latanoprost and bimatoprost, try to remember the first two names at least. Their side effect is very important. Due to inflammation in eye, you will feel grittiness in eye, sandy eyes. Sandy eyes. Anterior uveitis. Now, when they go to the retina, they will cause retinal inflammation, which will appear like small cloud-like spot. This is known as cystoid macular edema. Because of this reason, these drugs are contraindicated in diabetes mellitus. Which drug should be avoided in diabetes mellitus? Because in diabetes also there is cystoid macular edema. Agreed? Now, when they will damage iris, the color of iris will change. Iris provide color. Which drug produce heterochromia iridis? Prostaglandin. And they cause hair growth. You can see eyebrows size have been increased. That is why they are used for, prostaglandins are used for hypotrichosis. When you want to increase the hair growth in hypotrichosis, you can give this drug to your patient apart from glaucoma and additional use of these drugs. Fine? Additional use. Okay. Now, an epilepsy patient. So we already have discussed this question. Try to answer. An epilepsy patient is taking retigabine thrice a daily. Now phenytoin is added. What should be done next? We already discussed. What should be done? Remember, stopping any drug suddenly will lead to rebound seizure. So never stop any anti-epileptic drug suddenly. So third answer is correct instead. You cannot change any anti-epileptic drug suddenly. Sudden change will lead to rebound seizure. So now the only option which is left is either the dose should be adjusted. Hence, we already know the answer and we know the reason. Phenytoin is an enzyme inducer. Increase the metabolism. Yes, Shurbisha. Hence, the dose should be increased. So, bacha log, remember, this is the list of CYP enzyme inducers and inhibitor. I have already told you in regular lectures. Just have a recap about them. Any drug which is a CYP enzyme inducer, you have to increase the dose of other drugs. You have to increase the dose of other drugs. Mnemonic is GPRSAS. Graciofulvin, all anti-epileptic except valproate. Rifampicin, alcohol and smoking. Fine. Here, these drugs, they increase toxicity of other drug. Hence, the dose of other drugs must be reduced. Okay. Hence, the dose of other drug must be reduced. So, this is a simple way to remember. Mnemonic is Coke, IVC, GAR. Okay. Coke, IVC, GAR. You have to remember them. Okay. Good. Good to go. Next question. Sodium bicarbonate is given in the poisoning of. This question was asked 6 months back in INI-CET. 6 months back, this question was asked. Try to answer, apply your mind and tell me. Apply your mind and tell me. The answer for this question is acetaminophen, which is another name of paracetamol. Now remember, if there is any weak acidic drug poisoning, we turn the pH of urine alkaline, because in alkaline media the drug becomes water soluble. So the drug of choice is sodium bicarbonate. Example, remember 4 drug? Aspirin. Antidote of aspirin is sodium bicarbonate. Methotrexate, we give this drug to remove in urine. Acetaminophen, which is also just like aspirin, NSAID, barbiturates. Similarly, in weak basic drug poisoning, we turn the pH of urine acidic, and we give a drug ammonium chloride. We give a drug ammonium chloride. Yes, and the drug are amphetamine, strychnine, morphine, atropine, quinine. So how we can remember? These drugs are ending with the word "ene" word will come. They are basic drug. So can you tell me antidote of amphetamine poisoning? Antidote of amphetamine poisoning is ammonium chloride. So let's write all antidotes at one place. All antidotes at one place. Okay? Chalo. Let's start a quiz session. Tell me the antidote of digoxin. कर रहे हैं वो भी करते हैं बेटा. Specific antidote. This is a non-specific antidote. This is just to remove a drug. NAPQI, I will be telling you shortly. It is to protect liver. Digoxin antidote. The antidote for digoxin is one monoclonal antibody digibind, also known as digifab. Diazepam, which is a benzodiazepine. Antidote is flumazenil. Antidote is flumazenil. Lignocaine. Anyone? Lignocaine. What is the antidote? 20% lipid emulsion. 20% lipid emulsion. Okay. Aspirin, sodium bicarbonate. Paracetamol, N-acetylcysteine. Why? To protect liver with sodium bicarbonate. Yes, beta, you are absolutely right. Lipid emulsion is also known as intralipid. You are absolutely right. Any local anesthetic poisoning, we give lipid emulsion. If I say not lignocaine, if I'll ask you benzocaine poisoning, bupivacaine poisoning, your answer should be 20% intralipid, because intralipid will keep this drug into the blood. It will not allow a drug to enter into the organs. Morphine or opioid poisoning, IV naloxone. Amphetamine poisoning, we just discussed the reason. The only drug we have is ammonium chloride. Tricyclic antidepressant poisoning, again sodium bicarbonate. Now the question which will come is that tricyclic antidepressant increase QT interval. Which drug to be given? The drug we give is sodium bicarbonate. Okay. Organophosphate and carbamate poisoning, the antidote is atropine with pralidoxime. Now remember, pralidoxime is only given in OP poisoning. Pralidoxime only in OP poisoning, not in carbamate poisoning. While atropine is given in all poisoning. Now one question which was asked is, atropine poisoning, one carbamate physostigmine. Physostigmine is a carbamate. So carbamate poisoning we give atropine. Always it is first and foremost, always it is N-acetylcysteine as a first drug of choice. Because we want to treat paracetamol poisoning only when the patient is having symptoms of liver failure. Liver failure is the main cause of death in paracetamol poisoning. Paracetamol itself is not the cause of death. Dr. Silver, there is a question I have prepared on paracetamol. We will come to this question after 2-3 questions. After few questions, I will be coming to specifically on paracetamol, and I will clear all of your confusion. Okay. Now methanol and ethylene. Okay, just remember, in atropine poisoning, you will find a symptom of hyperthermia. This was a recent question. Okay. Atropine reduce sweating. Reduction in sweating leads to hyperthermia. Methanol and ethylene glycol poisoning, a orphan drug omeprazole, but you can also give ethanol. So this is an indication that you can drink with your patient. Calcium channel blocker poisoning like verapamil, IV calcium gluconate, and propranolol or beta blocker poisoning, glucagon hormone. So glucagon hormone is an antidote of propranolol or beta blocker drug poisoning. So beta blocker causes bradycardia, glucagon causes tachycardia. Okay, glucagon causes tachycardia. Understood this point? Good. Let's come to the next question. Nivolumab is used for. Nivolumab is used for. It is glucagon first. Glucagon is the antidote for propranolol poisoning. Beta, no doubt in that. The answer for this question is Hodgkin's lymphoma. Okay. Now, a very important class of monoclonal antibody you must remember is, this is a very important part. Expect a question in INI-CET coming from past 5 years. There is a type of monoclonal antibodies known as immune checkpoint inhibitor. What immune checkpoint inhibitors they will do? They will increase immunity of the body, and this immunity will kill cancer. I hope in 2 words you have understood. Now remember one point, see this diagram. This is antigen presenting cells. When this antigen presenting cells goes to T cell, it suppresses T cell. Hence immunity reduce. How? Because it acts on a receptor known as CTLA4. CTLA4 suppress immunity. So we have a drug CTLA4 inhibitor. I hope you have understood. CTLA4 inhibitor. Can you tell me the first drug name? Ipilimumab. You have to remember the first name, ipilimumab. I will show you the slide also. Second point, this cancer cell, it has a receptor known as PD1. PD1 is program death receptor, and cancer cells has program death ligand. Fine. And when this receptors becomes activated, it decrease immunity. So can we inhibit this receptor also? So we have a class of drug, nivolumab and pembrolizumab. They are program death 1 receptor inhibitor. They block this receptor, which will improve immunity. Similarly, durvalumab, avelumab, atezolizumab, they are PD-L1 inhibitor, program death receptor ligand inhibitor. Okay, I hope you have understood. So this slide is very important for you. Now this slide, remember, one day before exam, because it's a highly volatile part, you have to see the slide. One day before this exam, you have to see the slide. First question, you have to remember this drug, ipilimumab. Which drug you have to remember? Ipilimumab. Tell me, ipilimumab blocks which receptor? It blocks CTLA4 receptor. Which two cancers we have to remember? Malignant melanoma, non-small cell lung cancer. I hope you have understood. Then you have to remember this drug name, atezolizumab. You don't have to remember every drug. I am marking them for you. They block program death ligand 1. Program death ligand 1. They are given for urothelial cancer. You have to remember. Other cancers are also there. Now, another brother is durvalumab. Durvalumab is approved for endometrial cancer. Now the question which was asked is, which two immune checkpoint inhibitor are given for endometrial cancer? The first is durvalumab. The second one is which other drug? Pembrolizumab. Pembrolizumab is also approved for endometrial cancer. Lastly, very important, nivolumab and pembrolizumab. They block receptor. They block receptor. Above drug, they block ligand. They block receptor. They block ligand. They block receptor. Three uses you have to remember. Malignant melanoma, non-small cell cancer. Sir, how we can remember? Very easy. Can you see these two? These two are also there. Same to same. Malignant melanoma, non-small cell lung cancer. Third, we have written separately. Hodgkin's lymphoma. So this is a trick how to remember. Okay, good. Now, drug not used in PCOS, polycystic ovarian syndrome. Anyone? In PCOS, the overall drug of choice is combined OCP, oral contraceptive pills. But still, if there is no improvement, then what we will do? First thing is, if there is still an ovulation, remember PCOS, OCP, they control all symptoms. Yes, this is a trick. Then you give clomiphene. You add clomiphene. Still not control, you add letrozole. Clomiphene is an SERM, selective estrogen receptor modulator. Letrozole is an aromatase inhibitor. It inhibits the conversion of testosterone into estrogen. If there is diabetes mellitus, then we add metformin. So metformin is given to control diabetes in PCOS. Third, if the female is having hirsutism, then we give anti-androgen, that is spironolactone, cyproterone. Fine. Lastly, if the female is having dyslipidemia, then we add, bad lipids are increased, we add statins like rosuvastatin, atorvastatin. Now can you tell me the correct answer? I have told you the treatment of everything about PCOD. Now one more point. For the treatment of hirsutism, there is another drug known as eflornithine. Eflornithine is a topical hair remover cream. Topical hair remover. I hope you have understood. So the answer for our question comes out to be is tamoxifen. So where tamoxifen is used? Tamoxifen is given in ER positive breast cancer. Tamoxifen is given in breast cancer. Can you tell me tamoxifen itself increase the risk of which cancer? Tamoxifen itself increase the risk of endometrial cancer. Tamoxifen is given in breast cancer, but tamoxifen increase the risk of endometrial cancer. Next question. This question was asked previous year, 1 year back. Paradoxical bronchoconstriction is seen with ipratropium due to all we have to find except, just a moment, except anyone, except you don't have much time to answer very fast. The answer is C. Answer is C. Okay. The answer for this question is C. Let me tell you about ipratropium. Actually, it is a bronchodilator which is used in the treatment of asthma and COPD, but in some patient it causes paradoxical bronchoconstriction. Let's see the reason why. Why ipratropium causes normal bronchodilation? Why it causes bronchodilation? Suppose this is a vagus nerve which is coming on bronchus. On our bronchus, we have M3 receptor. It causes postsynaptic M3 blocker. When you block M3 receptor, muscarinic receptor, it leads to bronchodilation. But it causes paradoxical bronchoconstriction because on this vagus nerve we have M2 receptor. It causes blockage of presynaptic M2 receptor. Blockage of this presynaptic M2 receptor on vagus nerve causes more release of acetylcholine, and acetylcholine causes bronchoconstriction. First reason. Second, the inhaler of ipratropium contains certain antibacterial preservatives like EDTA, benzalkonium chloride. They irritate bronchus, which leads to paradoxical bronchoconstriction. Now, this paradoxical bronchoconstriction, which is seen with ipratropium, is not seen with tiotropium. Now, can you tell me 3 reasons for it? Why tiotropium does not produce paradoxical bronchoconstriction? The first reason is tiotropium does not block presynaptic M2 receptor, and the inhaler of tiotropium does not contain EDTA, and inhaler of tiotropium does not contain benzalkonium chloride. These are certain antibacterial preservative in inhaler which may irritate bronchus and cause bronchoconstriction. Fine. Yes, adenosine also causes.